Very good morning. Today the class is on prognosis and treatment plan. From this class, we would like you to know the different types of prognosis. 5 different types are there, and explain the reason for the proposed prognosis. Prognosis is a prediction of a probable course, duration, and outcome of a disease. This is based on a general knowledge of the pathogenesis of the disease and the presence of risk factors for the disease. The prognosis is established after the diagnosis is made and before the treatment plan is formulated. So, in other words, prognosis generally is done once your examination and diagnosis is done, and this tells how the disease is going to go on its course. It is just a prediction how the disease will be, and based on this our treatment plan will be. So, prognosis is based on a specific information about the disease and the manner in which it can be treated. It is also influenced by the clinician's previous knowledge with treatment outcomes. It could be either with the clinician's successes he encountered or Now, coming on to the difference between the prognostic factors and the risk factors. Prognostic factors are characteristics that predict the outcome of the disease once the disease is present. In some cases, both the risk factor and prognostic factors can be the same. Patients with diabetes or smokers are at more risk for getting the periodontal disease, and once they have it, they will have a worse prognosis. So, in this case, diabetes or smokers is both a prognostic factor as well as a risk factor. It is important to note that the determination of prognosis is a dynamic process. As such, prognosis is initially assigned should be re-evaluated after completion of all phases of therapy, including the periodontal maintenance phase. Careful analysis of factors allows the clinician to establish one of the following prognosis. So, it could be either an excellent prognosis, good prognosis, fair, poor, questionable, or a hopeless prognosis. So, coming on to the classification schemes of prognosis based on evaluating the tooth mortality. So, a condition in a patient is said to have an excellent prognosis if the particular tooth has no bone loss, tooth or the dentition as such has no bone loss. It has an excellent gingival condition if the patient is a good cooperative patient and the patient has no systemic or environmental factors. In that case, if there is any disease, if there is any condition in that patient, we term it to be an excellent prognosis. So, we term a condition to be a good prognosis if the individual has a good control of etiologic factors, has adequate periodontal support, insurance that the tooth will be easy to maintain by the patient and the clinician, then such a dentition or a tooth will fall into the category of good prognosis. Fair prognosis, approximately 25% of attachment loss if it is present, or if there is a class 1 furcation involvement, less than adequate remaining bone support, some tooth mobility, presence of limited systemic or environmental factors. In that case, we place the condition or the tooth or the overall dentition under a fair prognosis. So, in this case, location and depth allows proper maintenance but with good patient compliance. So, if the pocket's depth or location allows the patient to maintain it well and the patient is able to maintain the condition well, then the overall dentition falls under the fair prognosis criteria. Coming on to poor prognosis, there is 50% of attachment loss with class 2 furcation involvement, moderate to advanced bone loss, tooth mobility, presence of systemic or environmental factors. Then such condition is termed to be poor prognosis. Questionable prognosis, if there is more than 50% of attachment loss, poor crown to root ratio, poor root form, class 2 furcations which makes the location and depth little difficult to access, or class 3 furcation involvement, more than grade 2 mobility, root proximity, advanced bone loss, grade 2 and grade 3 furcation involvements, tooth mobility, inaccessible areas, presence of systemic or environmental factors. So, if a tooth or the overall dentition has any one of these categories, then they fall into the questionable. The last one is hopeless prognosis. If there is inadequate attachment to maintain the health, comfort or function, advanced bone loss, non-maintainable areas, extraction if it is indicated for a particular teeth, presence of uncontrollable systemic or environmental factors, then that particular condition falls under the whole. So, factors to consider when determining a prognosis. So, generally we consider the overall clinical factors such as the patient age, the disease severity, plaque control, patient compliance, or the systemic and environmental factors such as smoking, systemic disease or condition, genetic factors or stress, local factors such as plaque and calculus, subgingival restorations, anatomic factors. This involves around the particular tooth, for example, short tapered roots, cervical enamel projections, enamel pearls, bifurcation ridges, root concavities, developmental grooves, root proximity, furcation involvement, and tooth mobility. Prosthetic and restorative factors such as abutment selection, caries, non-vital. There are various types of prognosis which are present according to the work we are doing. It could be a diagnostic prognosis. So, this is generally formulated when you are evaluating the course of the disease without the treatment. What is the status of the teeth now, and what could be the anticipated future of these teeth? Therapeutic prognosis, given the state and art of science of periodontics and the knowledge and skill of the practitioner, what could be the effect of periodontal treatment on the course of the disease? So, prosthetic prognosis, given the anticipated result of the periodontal treatment and the periodontal health status obtained for the patient, what is the forecast for the success of prosthetic restoration? Will the processes be therapeutic or it would be detrimental? So, that dealing with the processes part is a prosthetic prognosis. Provisional prognosis, it will allow the clinician to initiate the treatment of teeth that have a doubtful outlook in the hope that a favorable response may tip the balance and allow the. Now, factors to be considered. Generally, the patient factor, clinical factors as well as the local or environmental factors play an important role in evaluating or coming. So, again as I told you, it could be either an overall prognosis or an individual tooth prognosis. The overall prognosis is concerned with the dentition as a whole, whereas the individual tooth prognosis is determined after the overall prognosis and is affected by. Coming on to the relationship between diagnosis and prognosis, generally prognosis is formulated for patients with gingival disease such as those with diagnosis of gingivitis associated with dental plaque, plaque-induced gingival diseases modified by systemic factors, modified by medication, modified by malnutrition, or it could be prognosis for patients with periodontitis with diagnosis of chronic periodontitis, aggressive periodontitis, periodontitis as a manifestation of systemic diseases, periodontitis as such, and necrotitis. Generally, the flow chart or the way you are going to see a patient and go about with the treatment of the patient is to be followed in this, what is there in this flow chart. You first go on with the examination of the patient, extraoral as well as intraoral, then go on with formulating your diagnosis. Then after, with the help of examination and diagnosis, you give a prognosis, that is you predict the course or outcome of the disease, and with that all these three you formulate a treatment plan and go about with it. So, diagnosis requires thorough and careful examination. Prognosis is based on accurate diagnosis. Treatment decisions are based on prognosis. Treatment decisions are made to improve the prognosis. Diagnosis and prognosis will change. So, the highest key to success is your treatment planning, but the building blocks for this is your evaluation, that is your clinical evaluation, diagnosis and prognosis. In other words, these three has to be correct for your treatment to be planned correct and for the treatment and for the patient to. Coming on to the next part. So, in this case you are going to develop an exact treatment plan, rank various treatment options based on prognosis, adjust the treatment plans based on the patient's requirements. So, these are the learning outcomes from this particular. So, coming on to the periodontal decision tree. Whenever you evaluate a case periodontally and if you find attachment loss in that particular case, you go in for, if the disease is not controlled, you go in for scaling and root planing. But if you could control the disease, just place the patient on periodontal maintenance. Now, once the patient has undergone scaling and root planing, you have to reevaluate the patient. So, when he has gone in the reevaluation phase, if you find that the patient is having attachment loss, but he has excellent hygiene and the disease has resolved back, that is, the attachment loss has reduced, in that case you can go for periodontal maintenance. Or in other words, if there is an excellent hygiene but unresolved pockets, you can go in for surgical therapy. Or if the patient has poor oral hygiene, then he is not an ideal candidate for surgical therapy. You go in for non-surgical therapy and put him in the reevaluation phase until he goes into an excellent hygiene therapy. Next, if the patient has no attachment loss, and in that case if he is just having little localized inflammation, you just go for prophylaxis. But if he is having a generalized to moderate severe inflammation, you go for scaling, you reevaluate it again. If the disease is resolved, then put the patient on prophylaxis treatment alone. So, this is the whole periodontal decision treatment tree. So, with this the cases can be easily evaluated and a treatment plan can be formulated for all the. Maintenance of the health depends on the disease prevention, meticulous daily patient home care, and patient adherence to professional recall maintenance at a regular interval. The immediate goals are the elimination of all infectious and inflammatory processes that cause periodontal and other oral health problems that may hinder. The intermediate goals are the reconstruction of a healthy dentition that not only fulfills all the functional and aesthetic requirements but lasts for many years. Whereas the long-term goal is the maintenance of a health through prevention and professional supportive therapy. The long-term goal is set and both the patient and the clinician work towards it from the very first. The treatment plan is a blueprint for the case management. It includes all the procedures required for the establishment and the maintenance of the oral health and involves decisions regarding the emergency treatment, removal of non-functional diseased teeth, possibly strategic extraction of healthy teeth to facilitate the prosthetic reconstruction of the patient, treatment of periodontal diseases such as surgical, non-surgical, endodontic therapy, whether it is necessary or it could be an intentional one, caries removal, placement of temporary and final restoration, occlusal adjustments and orthodontic therapy, replacement of missing teeth with removable or fixed dental processes, aesthetic demands. The preferred sequence of therapy is this method. So, generally when a patient comes to you, if he is having any emergency, you treat that first and then put the patient into the non-surgical phase. So, once the non-surgical phase is over, you put the patient into the maintenance phase. After this, you put the patient into the surgical phase, then into the restorative phase. You can see very well that this order has to be followed correctly, and maintenance phase is always the heart of your. So, coming on to the preliminary treatment, the preliminary treatment involves treatment of emergencies such as dental or periapical, periodontal abscesses or other cases. Extraction of hopeless teeth and provisional replacement, if needed, may be postponed to a more convenient time, especially during the phase 2 therapy. The phase 1 therapy or the non-surgical phase includes that of the plaque control and patient education, wherein diet control, removal of calculus and root planing, that is your scaling and root planing, comes under the non-surgical phase. Correction of restorative and prosthetic irritation factors, excavation of caries and restoration, antimicrobial therapy, occlusal therapy, minor orthodontic movement, and provisional sprinting and processes comes under the, by which you go in for evaluation of response to this non-surgical phase, where you check for the pocket depth and gingival inflammation, plaque, calculus and caries once the non-surgical phase is done. This is exactly done 1 or 2 weeks after your non-surgical phase. After this, we go on to the phase 2 therapy, that is your surgical phase. Periodontal therapy, including placement of implants, come under this. That is followed by even if there is root canal therapy to be carried on, then we put them under the surgical phase. The third one is your restorative phase, where you go for final restorations, final fixed and removable prosthodontic appliances, evaluation of response to restorative therapies, and periodontal examination. Maintenance phase, where there is periodic rechecking of plaque and calculus. Gingival condition, for the pockets and inflammation, occlusion, tooth mobility and other pathologic changes are checked during the maintenance phase. As I told you already, maintenance phase forms the. So to conclude, the ultimate goal for every patient is to bring his or her mouth to a state of health and maintain it long term. This begins with educating the patient on the problems in his or her mouth and the etiologies and treatment and prevention of these problems. A properly formulated treatment plan is a paramount to achieving this goal. A treatment plan is a plan for therapy formulated only after a thorough examination has been completed, diagnosis and prognosis have been determined, and the needs and desires of the patients have been taken into consideration. So it must be recognized that as diagnosis and prognosis will change with treatment, therapeutic needs may also change. The treatment plan must be changed accordingly.